So thank you for joining us for our fourth Brain Matters webinar series, Ageism and Dementia, with Laura Tamlin Watts, Dr. Nathan Stahl, and David Harvey. My name is Susan Oster. I'm the Coordinator, Dementia-Friendly Communities with the Alzheimer's Society in London and Middlesex. At the Alzheimer's Society, our role is not only to provide programs and services for people who are going through the journey of dementia, but also to provide dementia education and to advocate for those living with cognitive disabilities. So we did want to recognize the generous support from Ian Wright of Scott Petrie Law Firm, and I am very pleased to share a special greeting from Ian.
Thank you for the opportunity to participate in the Alzheimer's Society's Brain Matters webinar series. My name is Ian Wright, and I am a partner with the Scott Petrie Law Firm. I am really looking forward to the panel discussion covering an issue that the pandemic has certainly highlighted, the problem of ageism in Canada, particularly through the lens of dementia and dementia care in our country. Scott Petrie and I are pleased to support the Alzheimer's Society of London and Middlesex as the presenting sponsor of today's session. On behalf of my firm, I'd like to welcome you to the session and hope you find it engaging, informative, and inspiring.
So just a few points to help you enjoy this webinar and get the most out of this experience. Your cameras are off and your microphones are muted for the webinar. So this event is being recorded and will be available in future on our website. And because you're attending, you will actually get notified when that becomes available. If you've attended our webinars before, this month will be a little different. The panel will be discussing several themes related to our topic of ageism and dementia. If you have any thoughts or comments on what is being discussed, please type in the chat box. So you may need to move your cursor around to see the Zoom controls and icons. So we will respond to as many comments and questions as we can. And there will also be a little bit of an extra Q&A time at the end, but certainly if you have any comments or questions, please send them throughout the discussion. And just a note, you can submit your comments and questions to all attendees and panelists, so that those will be viewable by everyone, or just to the panelists. So you can kind of select that on your chat box. And should you have any technical concerns during the webinar, again, please also put those in the chat box. So just a quick disclaimer. So please note that the opinions expressed by participants are their own and not necessarily the representative of the Alzheimer's Society in London and Middlesex. So today we have the pleasure of welcoming three expert panelists. And please note that their full speaker bios can be found on our website, and you would have likely seen those when you registered. So just to save some time, I'll do some quick introductions of our panelists right now. So Laura Tamlin Watts is President and CEO of CanAge. She is a lawyer, advocate, researcher, and media commentator. She was actually just on the media right before this webinar. Thanks, Laura. And her work focuses on law, aging, abuse, accessibility, law reform, excuse me, governance, and knowledge mobilization. She currently teaches at the University of Toronto, where she is a fellow of the Institute of Life Course and Aging. Dr. Nathan Stahl is a geriatrician with Mount Sinai Health System. He received his medical degree from Western University, yay Western, and completed his residency in internal medicine and fellowship training in geriatric medicine at the University of Toronto. He is currently a research fellow at Women's College Research Institute at Women's College Hospital and is completing a PhD in clinical epidemiology and healthcare research at the University of Toronto. And finally, David Harvey is producer and host of Dementia Dialogue. He leads the development of the Dementia Dialogue project, which features a series of podcasts covering various and important topics in the dementia space. David has worked in the field of aging for several years and has focused on creating opportunities for people and communities to build their capacity to determine their future. Prior to starting Dementia Dialogue, David served in senior management with the Alzheimer's Society of Ontario and the province of Ontario. So welcome, Laura, Nathan, and David. So I am going to stop sharing right now. And I am actually going to start with a poll just before we jump into things. So for our attendees, since we can't see you, it would be great to learn a little bit more about you. And here we go. So hopefully, and I've actually allowed our panelists to vote as well. So you should see some poll questions coming up, and I'll give you a few minutes. There are 2 questions, so please scroll down. So there's a question 1, and if you scroll down, you'll see a question 2. And please note that these are anonymous, so we can't tell who is answering which question. So I'll give you another little bit of time here. We've got about 75% of people have answered. Okay, so we'll give you another about 5 seconds just to make sure that everyone's had their coffee. There we go. David just took another sip there. Excellent. Okay, so this is what we have, the attendance today. So it looks like the majority of people attending are care partners and friends, so welcome, and then another big contingent from the community support services. And in terms of age, the majority, again, about more than a third are in the 65 to 79 age group, and then we see another big group in the 49 or younger. So very interesting. Okay. We are going to launch into things. I'm just going to get out of here. There we go. So today, again, we'll have 3 general themes, and you may have seen this when you registered, as part of our discussion. And as Laura put it so eloquently, the what, the so what, and the now what of ageism and dementia. So thanks again, Laura, for sharing that very concise phrasing. So I'm going to actually start with Laura. And again, each of our panelists will have an opportunity to kind of chat back and forth. And Laura, you regularly speak in the media, again, as you mentioned this morning, about ageism in our society. So what exactly does ageism look like, and how pervasive is it?
Whenever I'm asked why, like, why are we in this circumstance in COVID-19? Why were we in this circumstance before COVID-19? Why are we still having this conversation? Why haven't well-established recommendations been implemented? Now, the answer is really fundamentally always the same. It's ageism. There is always money, time, attention, policy, and implementation for things that we value. And I challenge you to even just think of what it would be like if we were having this set of experiences pre-COVID or post-COVID, post-COVID, during COVID, sorry, to any other age group. And so when we're looking at ageism at its most fundamental, we're asking about how is a person being treated differently because of their age? And I don't think we can have any more stark example than people's basic care needs not being met. And by that, I mean things like toileting, bathing, food, water, necessary care, social engagement, being locked up. What does it look like most recently? it looks like management taking the doorknobs off of the homes in a retirement home, which is a tenancy that someone individually pays for, and illegally incarcerating them because they've decided that their lives and their rights are not as valuable as others. It couldn't be more stark.
And Laura, where else do we see, again, I know we've certainly seen this really come to the forefront during COVID and really horrific examples as you've highlighted. Where else do we see examples of ageism in our society? That maybe people aren't, they might not think of them as being ageism.
I challenge you to go into any gift store, any grocery store, and go to the greeting card section. Open up any birthday card and then change the word old or geezer or age or any other reference to any other type of group. I challenge you not to be horrified. Ageism is the last acceptable, and of course I'm using that very much in quotation marks, of course it's not acceptable in any way, it's the last socially acceptable form of discrimination that is allowed on greeting cards. It is allowed in workplace jokes. It can be institutionalized in our laws. An example, of course, exists within the concepts of mandatory retirement. It also can exist sometimes in how we think about triaging. And we know that, of course, value is placed where we decide to place it. And what we have not decided to place it is here. And so ageism really subsumes our work life. It subsumes our birthday greetings. It is included in how we are portrayed on television. It is in commercials. It is really an unchecked form of discrimination, and it has to stop.
Thank you. And David, I'm going to come to you next. And thinking, we talked about this when we were kind of planning for this series or with this webinar. And in what ways do you see ageism occurring among older adults themselves? So, and how do you think this relates to the stigma that we see associated with dementia?
Yeah, I want to pick up on a couple of Laura's comments. I think, we're really confronted at this point with a couple of other isms as well as ageism. I think when we're talking about long-term care and older people, we've got an intersection with issues related to women, because most of the people in long-term care are old women. Most of the people who have dementia are old women. And most of the people who work in long-term care are women. And in some of our communities, mostly racialized women. So I think there's a real intersection. If long-term care was full of old men, I think we would see a very different way of caring for people than the way we were doing it today. The other ism that I would bring into the discussion is around disability. And the stigma related to mental health and all forms of disability, including physical disability, also bleeds into how we then perceive people with dementia. Because indeed, dementia is a functional impairment of our mental capacity and sometimes our physical capacity. So I think we've got an aggravation of three forms of prejudice interacting as we look at this issue. The other thing I wanted to pick up on was prejudice isn't always malevolent. It's not always perceived as bad or recognizable as bad. It can be kind of benevolent and patronizing and paternalistic. So we see in the comments of our political leaders talking about loved ones or characterizing all people in long-term care as seniors, or talking about people who are vulnerable, and really emphasizing the vulnerability of people as opposed to their perhaps offsetting strengths, offsetting capacities. So I think we really need to kind of think through what are the components of this prejudice that is experienced by people today. The other point that I think Laura really emphasized was how it's manifest in the drugstore, in the greeting card section. But I would also say it's manifest in the way that drugs are packaged. I'm an old guy, and old guys suffer from some kind of disability related to their thumbs and fingers. And trying to open a prescription bottle is really challenging for old folks. So that kind of packaging and other ways that can be seen to be, in fact, a disabling kind of experience. A couple of days ago, my wife gave me some, a small tincture of an essential oil, lavender, and trying to open up that bottle was a real challenge. She cut herself twice trying to do it. So that kind of commercial application of ageism is really, I think, something that we experience. So I want to bring that to the, I think one of the most insidious aspects of these isms that we're talking about is leading to self-stigma. That is, we begin to buy in to that stigmatization. We may have participated in it as we were younger, and then we buy into it as we are older because it's reinforced by what we see in the media. It's reinforced by what we might experience. It's being reinforced by what we hear. And we can talk a little bit later on, but it leads to a sense of aging as a negative experience, old people as disposable, old people as incompetent, old people as vulnerable, that as we lose our memory, we lose our very being. And it can lead also to the over-medicalization. And I think that's one of the issues we're faced with in long-term care at the moment, is the institutionalization of old people and the over-medicalization of that care. And I'm not being critical of the people providing that care. It's the philosophy and the rubric surrounding that care that can be in itself a disabling experience. So I'll just kind of leave it there at the moment and we can continue our discussion.
Thanks, David. And a couple of points you made. I know you mentioned about the intersectionality, and that was really interesting. I was really hoping to get access to a recording of an interview that was on CBC's Fresh Air program Saturday morning, and I've reached out to them to try to access that. So if I get it, I will certainly share it in the follow-up materials. It was a great interview with a journalist, Judy Rebick, and she talked about that very point, and I see the others nodding, and really looking at, again, that very point. The majority of people in long-term care are women, and then from another point, the racialization as well, again, looking at most of the staff, and a lot of the staff are both women and from racialized groups. So looking at, again, all of those intersectionalities, and that's, why are we not paying more attention to this sector? And also the point about that institutionalization. I know if anyone attended our last webinar featuring Kate Swaffer, I'm not sure if Kate's on or not. I think she might have signed up. Again, talking about that, again, the idea of that we don't do that with other groups, that we don't lock people up in places. So these are certainly all very, very key concerns in our society. So Nathan, I'm going to pop over to you now, and we're seeing some things that are starting to come up in our chat box, which is great. And COVID has certainly, as the others have said, highlighted that the ageism that exists and has existed previously within our healthcare system. So what are some examples of how ageism presents itself within the healthcare system? And maybe think about some things that our attendees or people may not think about as even being ageist.
Sure. So thanks for having me. The other thing, just to preface it, that I would start with in terms of ageism and older adults is the fact that we have multiple and intersecting forms often of discrimination as it relates to older adults, and particularly those in long-term care. So we know that the majority of older adults are women because of the fact that women are the stronger and superior sex, so they tend to outlive men. And we also know that particularly in long-term care, where 70% of people have cognitive impairment, dementia, 90% have cognitive impairment, a lot of people live with dementia. And so you start to have these intersecting forms of discrimination, whether age-related, dementia-related, and also sex and gender-related as well. And so I think that's really important to think about. Yes, COVID has highlighted things that we knew always existed, and there's been many ways that this has manifested throughout the course of the pandemic. You know, I think, like, let's put aside what we know as sort of the gross neglect of certain sectors like long-term care for, you know, a multitude of reasons, ageism being one of them. But, you know, if we dig a little deeper in our healthcare system, older adults, we know, are more likely to have atypical presentations of diseases. So early on in the pandemic, testing for COVID-19 was tied to having typical symptoms for the virus, so fever and cough. We know, and geriatricians knew, and people with expertise in care of older adults knew, that older adults don't always or even commonly present with typical symptoms of an infection. They may present with confusion or falls or decreased appetite. And what did that lead to early on? Well, that led early on to people who had COVID-19 in long-term care homes not getting tested because they didn't meet criteria until the testing criteria were updated. And of course, we later learned from studies confirming what we knew, that 75% or 3/4 of people in long-term care homes who have COVID never have a fever. And so how is that ageism? Well, it's that lack of knowledge. Why do we not have that knowledge among our healthcare workforce? And that's because we don't invest in geriatrics, care of the older adult education. We don't promote it as a desirable field to enter. So, you know, in Ontario, we only have about 150 geriatricians. In 2015, in the province of Ontario, people age 65 and older overtook those age 14 and younger. But pediatrics is a very desirable specialty to enter into. We have more than 10 times as many pediatricians than geriatricians. And geriatrics and care of older adults is not something we value. So of course, when we have a pandemic like this and we need to rely on people who have expertise in care of the older adults to guide things like testing criteria based on symptoms, if we don't have that knowledge, and if the people at the table additionally are not those who have expertise in geriatrics, you lead to negative consequences like this, where you actually have real health impacts on individuals. So that's one example. I think the other example that Laura brought up about not recognizing in this population the role of family caregivers and the necessity of the people who support older adults, and that the same policies and visitor restrictions that we may have on businesses and other parts of our society, we need to adjust the dose. Just like we adjust the dose for medications in older adults, we cannot be applying the same public health principles to those who are older adults. You know, coming back to the pediatrics example, we talk about children in medicine not just being young adults, meaning you can't just apply the same evidence base and principles to kids that you can for adults. And in the same way, some adults, many older adults, are not just older adults, so to speak. There are differences that need to be considered very broadly. And you know, that's the case with the visitor policies that we saw as well. So those are two concrete examples, I think, of how ageism within our healthcare system has harmed older adults. And it stems from the fact that we have not invested in medical education, healthcare education, to have competency in care of the older adults, but also in a workforce that is interested in pursuing this knowledge and looking after this population.
Thank you. And I really, and thank you for bringing up, again, even the impacts on care. I know I've been with the society for over more than 11 years. And I know one of the first things when I started in 2009, there was a big push around better education around delirium, and maybe it's gotten better, but I just even educating, how do we educate family members about delirium and what to look for, because often they're the first line seeing people at home. And also, again, I've done a lot of work, and I'm sure my counterparts have in long-term care with frontline staff, about really driving home that importance of recognizing that, and that not putting all of our things into the dementia basket, because that can have, again, a really detrimental long-term impact on a person's health outcomes, and even how long they're going to be with us. So thank you very much for that. And I see some great comments in the chat box around education. Yes, sorry, David.
I want to just highlight one comment and address it to Laura, who is a lawyer. Christine Thelker's on the line, and Christine is from British Columbia and member of Dementia Advocacy Canada and the Dementia Alliance International. Christine raises the issue of these things like segregation and the locking of doors as being issues related to human rights, and in fact have some status in the law. And I'm wondering, Laura, if you could, if human rights cannot be enforced, then it's kind of in some ways a meaningless right. So I'm wondering what your suggestions would be around how we could strengthen human rights so that it's more enforceable and useful in situations like this, removal of door handles from long-term care.
Thanks for the question, David. I'm going to answer it in sort of what we call hard law and soft law. And, in hard law, we can actually take the underlying offenses or concerns and we can make them illegal, or if they're not criminal, then you can at least sue for them in civil court. So let's use the very specific examples of taking the door handles off and locking people. You don't need a human right for that. In a sense, of course, it is a violation of human rights, but it's also just illegal under the criminal code. It's called, wrongful detention. Like, it's already not allowed. And I think a lot of what we're really struggling with in the face of COVID-19 is many things that we kind of got away with because we just thought, we're not going to prioritize this group. People are looking at it with a very sharp lens right now and identifying crimes and in some cases, stark negligence. And so an example for that is right now in Quebec, we're literally today having conversations about whether or not the inquiry into Résidence Errant is going to go forward, because there are also criminal negligence charges being looked at the same time. So you can have hard law for the underlying offenses. On a soft law basis, our organization, CanAge, and many others are strong proponents and are working actively towards a UN Convention on the Rights of Older Persons. So, if you have human rights as a broad thing, that's great. But what we know is that human rights become much more effective, like for persons with disabilities or women or wherever, when you have identified areas, and then the governments have to report on those. So that actually is very important. We've certainly seen that with the Convention on the Rights of Indigenous People, is that then you put it into Canadian law. Same with UN Convention on the Rights of Older Persons. You've had to actually adopt Canadian law. So I think both that hard law and soft law are really important approaches.
Great. Thanks for circling back and speaking about that, because I know when I saw that news piece come up on the weekend or just before the weekend, I know I'm not a lawyer, but I was looking up what is the definition of unlawful confinement, and is there a way of, again, tackling this from a criminal perspective, because that was like really outrageous to hear that. Yes, so thank you for asking a lawyer about the law. And let's see, so I'm just checking our chat box here to see if there's anything else to bring forward. And again, I see, thank you, Sherry, for mentioning about just ageism when we're shopping. So when you're purchasing shoes, clothing, and again, makeup, it's assumed that people might be less physically or socially active and not being considered a group of importance for people shopping in that consumer aspect. And talking about conversations, I'm going to circle actually back to those informal conversations shortly. So I think we'll move into our so what question, and just see a note here. So I'm going to start with David. And David, you mentioned this when you first spoke, but I'm going to ask you to kind of delve a little more deeply into it, just in terms of language, and thinking about whether it be in the media or in everyday conversations that contribute to that othering. And I know we've talked about the othering of older adults and seniors. and particularly those living with cognitive impairment and dementia.
Yeah, I want to focus my comment on the issue of self-stigma. As I mentioned, as we over our last 60 or 70 or 80 years have kind of experienced this ageism and ableism and issues related to gender, we unconsciously incorporate that into our perception of the world. So self-stigma is really something that we're prone to as individuals, as humans. I think the other, because of our social setting, the other two things that come to my mind is kind of the word mindset. And I suppose it kind of moves into a little bit of philosophy, but often in our human experience, we can either interpret life as kind of fixed, predetermined, predestined, a kind of way that things can't change. Things happen to us, and we're kind of victims of that, of fate. The other is to perceive life in more of a changeable way, where we may have been dealt a certain set of cards, but how we play that hand determines the ultimate outcome. So there's an element of choice there. So I think when we are faced with an experience with aging in general, but also with the onset of a disability, how we respond to that disability is partially determined by that mindset that we may have carried throughout our lives, but certainly might become stronger as we grow older. If we've got a mindset around the fixed nature of life, or kind of a fatalistic mindset, a stigmatized mindset, it can really lead to self-isolation and withdrawal. If we're diagnosed with a dementia, even if we're not diagnosed, but begin to experience our interaction with people differently, then we can opt to withdraw from that interaction. We can begin to doubt ourselves, doubt our own capacity. Another mention in the chat box was, the idea of kind of checking out of things because we think it's too risky. So we can check ourselves out. No, I don't want to do that anymore because I might fall, or I don't want to do that anymore because I might not be able to follow the conversation. I don't want to play with our grandkids because I find it too rattling on my nerves. So it can also lead to us playing the victim. And I'll come back to that in a few minutes. But it has real consequences. And we know in the world of Alzheimer's is that people often seek help very late in the game. And so it's that kind of impeding of self-help. It can impede access to care. Physicians may not, so many people I talk with experience a physician not really attending to what the person is saying. And so access to care is a real issue. It can lead to a culture of silence. Roger Marple, another advocate in Canada, speaks to the issue of the culture of silence. I'm not going to talk about what's happening to me, and so nobody else in the room talks about it. They may talk about it among themselves, but they aren't going to talk to me. So that kind of cultural silence that can also lead to emotional isolation. So these are all things that the reason I'm focusing on self-stigma is not to blame people, but really to, these are things that we can do something about as individuals. And I think it is within the power of us as older people to begin to speak out and to begin to resist this pigeonholing and ascribing of characteristics that I don't feel. I must say, I'm 74 years old. I worked until I was 70, and then I've been doing this stuff. But when COVID set in a year ago, it was the first time that I began to associate myself with a vulnerable population of people. And it was not a very nice feeling. And it really kind of undermined what I thought, was just another stage in life. And so I think that kind of conversation really needs to be addressed. When you think of playing the victim, I want to speak about a couple of things. Our generation has more wealth than any other generation in society. So we're hardly victims from an economic perspective. On the other hand, we may be victimizing some of the people in our age group who suffer from economic hardship. So we're not all victims. Sometimes there are groups within our age group, but generally speaking, the majority of us have more wealth than anybody has ever had before, and chances are have more wealth than anybody will have afterwards. So it's important that we not paint ourselves too weak at this point in time. It's also important for us to take responsibility for having fought for many years for lower taxes, for the undermining of the social safety net. When we were young people and going to university, we had a much lower tuition burden than kids have today. The result of that higher tuition burden is a result of the way we cast our ballot over the last 40 or 50 years. So I think we need to take some responsibility for the situation we're in. Also, when we talk about the private long-term care sector, those private companies are owned by people who are our age. Indeed, many of us may have shares in some of those companies. I know my wife and I, until a few years ago, and thankfully I could demonstrate that it was before COVID hit, we had shares in Sienna Corporation. It's a widely held public equity company. And we decided a few years ago that, this was talk about ethical investing. Similarly, we know that Rivera is a company that the largest shareholder is a public pension fund. So we need to kind of shake out what our generation, the stake that we have in some of these issues, because these are things we can do something about. We're not always victims. So when we talk about stigma in terms of personal behavior, let's break the culture of silence. Let's speak out when we hear jokes about aging. Let's speak out when we see our friends that might be self-limiting in their capacity because they're feeling self-stigma. But also let's take responsibility from a societal perspective for our contribution to some of these issues, because it's taking responsibility that's the first step to changing things. So I'll leave my comments there for the moment. They might be a little bit provocative, but that's the point of this discussion, I guess.
Thanks so much, David. That was really, and again, you've really evoked a lot of comments in the chat box. That's a really great discussion that is happening. So I think you've really struck a chord here. And again, a comment, from Michelle about self-stigma, and when does that start? At what age? And I've heard many talks to say ageism is one of those things where we're all going to get older, so it's something that we're all going to face. It's not that we cannot get old again as long as we live long enough. And again, sorry, Laura.
On the self-stigma piece, it's really important because we do need to understand, and Michelle's comment about, embedding ideas of ageism, throughout is really important. There is a sort of pathetic joke that many of us play in the field, and I'm curious if you who are attending have played or noticed a similar circumstances, which is when you talk about age, I kind of set a clock. It doesn't matter. I could be in a geriatric situations, specifically talking about geriatrics or gerontology. And we will start a clock, and Nathan's smiling because he knows what I'm going to say. And we will wait to see how many minutes it takes before we start talking about children and youth. It is astonishing. We cannot seem to keep our focus on older populations, and that slippery narrative is one which I think we also need to hold ourselves to account for, because we start talking, we're going to carve out this unique space to validate and explore the issues associated with older age. And it doesn't matter whether it's an academic conference, often in the media, whether it's in common conversation, or even really any deeper exploration of the issues. It slips so quickly to children and youth. And I think that speaks to the fact that there's something about it that we actually can't bear to have a conversation around. So again, that piece, not just about self-stigma, but also some really present thinking about, am I just going to slip back into child and youth, or am I going to actually stick myself into this conversation, which may feel uncomfortable, and address it head on? Ageism is also not giving the respective time and attention, and we need to be thinking about that.
Oh, thank you very much for bringing that forward. And and again, one of the, just a little aside, one of the reasons I asked people how old they were when we started this with the poll is just to sort of think about, I think sometimes where we're on the border between age groups, we're thinking, well, at least I'm in this great age group and not in that age group. And we sort of almost other age groups, and to think about that, especially as we're I'm in my 50s and thinking about that. But I agree, Laura, sometimes we think about how do we shift to that younger age group and think about their role, or I know we talked about intergenerational, like do we, rather than just focusing on that older age group. So Nathan, I really want to thank you. And I know before we started, we talked about a great article that you shared with our panel group by a doctor out of Harvard, Dr. Sharon Inouye, and talked about ageism in healthcare. And what do you see as the biggest age-related healthcare challenges, again, in Canada, and particularly those that are impacting people with dementia and their care partners? And you touched upon that a little bit when we first started, but thinking really about why the so what of this. So why is this so important to talk about?
Yeah, thanks. And that article talked about building what they referred to as an anti-ageist healthcare system. And I think that starts with acknowledging the many insidious ways that ageism is really baked into our healthcare system. I spoke about atypical presentations of disease. I spoke about the lack of knowledge in healthcare professionals. But there are many other things that actually prevent older adults from actually accessing the healthcare system in the first place. Barriers to care. The way, this is playing out right now in the vaccine rollout in many places across the United States, and probably will happen in Canada as well, when we build systems to access care that are reliant on technology and ways of accessing that favor more computer literate individuals, those with cognitive and sensory, or those without cognitive and sensory impairment. I also think the evidence base that we draw from has fundamentally excluded older adults as well from clinical trials and research, particularly people living with dementia. Thankfully, we've made a bit of progress with that in COVID-19 in terms of the vaccine trials actually purposely included older adults, which we were able to show, because one of the arguments early on was going to be, well, we shouldn't be giving this vaccine to older adults if it hasn't been tested on them. The same thing we're seeing play out with pregnant and breastfeeding women. And so thankfully, the trial actually oversampled older adults and showed that it was just as effective, because there was a clear population level reason to be giving the vaccine to older adults. So when we talk about building an creating or refining a healthcare system that is anti-ageist, it is about baking that into all the fundamental structures of our healthcare system, from education to access to care to approach to care, one that considers atypical presentations of disease, that embraces the family caregiver as an essential partner of care. And it's building an evidence base that also incorporates the unique needs and preferences of older adults, so that we can actually have a better, I would call it, age-based literacy amongst our healthcare system and amongst our healthcare providers. Because if we don't remove barriers to care and actually have providers that understand what the needs are of older adults, we will never have a healthcare system that fundamentally meets their needs. And that's, I think, what we have seen time and time again in COVID-19. I think that there are many times where there has been, I actually, there are clearly examples that we've discussed today of, evil in terms of how we have harmed older adults, like removing door handles. But I actually think the majority of things that happened in COVID-19 are not sort of nefarious characters acting in terms of evil acts of commission. Most of it is acts of omission and a lack of knowledge about older adults that has led to their harm. And I think that's the larger responsibility of all of us in terms of why we do not have a healthcare system that embraces older adults. Clearly, I'm not exonerating the nefarious characters that have led to preventable death and harm, but I think overall, if you think about the course of events in COVID-19 in particular, we have sort of never missed an opportunity to overlook the needs of older adults, like at every single stage of this pandemic. And I think, unfortunately, even, top of mind now is the vaccine rollout. We are missing opportunities again to, prioritize older adults, to quickly vaccinate long-term care homes, to build systems that make the vaccine accessible for them. And I think that, building an anti-ageist healthcare system will take time and will take an investment. And I think in this larger conversation about what to do regarding what we have seen in the wake of COVID-19, it's not just going to be about long-term care, or it should not just be about long-term care. It should be about the continuum of care and building a healthcare system that promotes really anti-ageism.
Great, thank you. And I'm going to circle back to this again when we get to our now what. Laura, and thank you so much for adding. Ashley, this is going to be around the question I was going to ask you, so you're already ahead of the game on this front. But I wanted to say again, I know CanAge's mission and verbatim, again, is to advance the rights and well-being of Canadians as we age. So why in 2021, and I think we appreciate this, do we need organizations like CanAge, and why is your work so important? So certainly highlight some of the articles that you're putting into the chat box.
Well, that's the kindest introduction to talk about your organization that I've ever heard. I will happily do so. So CanAge is Canada's not-for-profit, nonpartisan seniors advocacy organization. We are really offering to raise up and lend a voice. We're not trying to sell you stuff. We're really just trying to ensure the best research, the best engagement, and make sure that the voices of older people are included in society, and as all people as they age. So you see that we're really looking at the words age inclusion. We're building on, of course, narratives of age friendliness and so on, but in our view, you don't need to be friendly if you've already been inclusive, right? You don't need to be working backwards if you've already actually done it in the first. We created a roadmap where we engaged in, frankly, thousands of expert interviews. We engaged in, transdisciplinary research. We worked with, Campbell and Cochrane collaborations for our friends who are in the academic field. And we put together, the commissions and the inquiries and the unrelenting number of white papers and policy papers that we've had for years. And we synthesized it into a roadmap, which is really, we picked up the pen for Canada and kind of put it in one place. What do we need to do? I'm not saying it's an exhaustive list, but it is a focus list. We talk about the voices of Canada's seniors and really encourage people to pop over to canage.ca/voice to look at it. We talk about violence and abuse prevention, optimal health and wellness, infection prevention and disaster response. We talk about caregiving, long-term care, home care, and housing. Again, not putting it in the health system, but looking at it across the housing continuum. We talk about economic security and social inclusion. And I've just put for you in our social inclusion, one of the key issues, which of course is, ageism, and we see that very specific issue with very actionable items underneath issue 38, is address and reduce ageism. And then we're trying to make sure that people can actually action it out. It's not all government, it's not all federal government, it's not all provincial government, it's not all municipal government, it's a lot of us. And so we're calling on private industry, we're calling upon organizations, not-for-profits, communities, and us to be able to change the ways that we are. So those are some, really love for you to join. It's free to join, it's an open door, and it will help us capture your voice. But I mean, if I think about what in social movement theory, for those of you who like to think about these things, I think we're about 30 years behind the women's movement, 20 years behind the disability movement, 10 years, I think, behind some of the Indigenous movements. And I think right now the conversations that we're having at the pointy end of the stick really is on the elder rights movement. And there's opportunities like this to have these type of conversation that lets us bring our voices together. And that's the goal of CanAge, is to just provide an opportunity and a chance for people to include their voices.
Thank you. And I see a great comment that's come up, and again, I think it's just come to us. Again, the result of ageism is death. The same result with Alzheimer's. Why do we not talk about death from the positive side that goes on at a hospice? So again, we might not talk about, again, I think that's just that general discomfort with death, and that may have some associations with ageism as well. So thank you for sharing that. And we will certainly include information on CanAge when we send out the resource page with this recording. So thank you very much. And so we have a question actually from my colleague about the membership fee. So, keep trying to keep it free. Okay, thanks very much. So if you are looking to be a member of CanAge, again, it's currently free, and they are going to endeavor to keep it free.
And you'll see that all of our events, we don't charge for the events. The goal is inclusion. We'll knock on the door of organizations that have money and say, here, please help, in the way that your generous sponsors as well. We know, that people want to participate and raise their voices up, and we're really committed to trying to make things as barrier-free as possible.
Wonderful, thank you.
I wanted to pick up on Laura's comments about social movement, if you will, because that just kind of leads into a thought that I had as we kind of move over to the now what or next stages. Hey, Susan, is that kind of where we're heading?
Getting there, yeah.
Yeah. So, because I think Laura's comments are really important when we think of this age group, and the majority of people on the line here are part of the generation of people where advances were really made in terms of women's rights. Advances were really made in terms of gay rights, in terms of disability rights, and in terms of Black Lives Matter, Indigenous rights. There's been a huge change in the last 40 years in all of those areas. So I think this generation is poised to make some difference in regards to ageism, ableism in terms of dementia, and to further the rights of old women. Because I think in some ways, just as women's rights, it was still lots of issues around lower economic women. There's still lots of issues around old women. So I wanted to think back to the phrase culture of silence, and to really ask people to think of how they could take individual steps to break the culture of silence within their own lives or within their circle, and to be more open to talking about what's happening to them as older people, or what's happening to them as a person with dementia. I had a friend who sadly now he's in long-term care, younger than I am. He developed frontal temporal dementia. And before the diagnosis, we all knew something was wrong. But the one difference in his life is that he was very open to sharing the fact that something was going on. his mind was not what it was 2 years ago. And it made such a difference in terms of how people responded to him. Now, sadly, there were still experiences of isolation, of people pulling back, but it also was an invitation for people to step forward. And I think that's such an important thing, is to end that culture of silence. And it's something that each of us can do something about. We all can't change the mind of the likes of Doug Ford, at least in the short term. We can change Doug Ford in the long term, but we can begin to make individual steps to change. The other thing I wanted to mention was to go to the intergenerational piece, is to rekindle the idea of a social contract and the idea of fairness and social justice among people in society. These have become very out of vogue terms, but it's brought us to the place where we are today. And I think we need to start thinking of intergenerational fairness. When we talk of age-friendly communities, what's good for an 85-year-old is good for a 5-year-old and a 15-year-old as well. These are not age-specific things. Having adequate recreational space, having places along the street where people can sit. I walk around with my 2.5-year-old, and I can tell you, having access to washrooms is as useful to a 2.5-year-old as it is to a 74-year-old. So these are things of intergenerational fairness. The issue of vaccinations, which is right on us today, is a complex ethical problem, but it needs to be brought into the open and have people reflect on it. This morning we were listening to the news, and my wife kind of reflected that perhaps an adult from a racial group in Toronto who necessarily lives in a multi-generational household, who works in long-term, who may not work in long-term care, but works in an essential place, is as vulnerable to COVID-19 as an 80-year-old. So we need to carefully weigh the issue of risk. And that risk is not owned just by old people, but it's owned by other generations. And in fact, old people may be at risk of death, but another person may be at risk of a longer term consequence of having COVID-19. So it's a complex issue, and we need to bring to bear a variety of different values, but an underlying value of fairness. And as we understand the various risks, we understand it in a different kind of way. And also it's important that we need to think of these things when we're talking about a post-COVID economic recovery. The people who suffered the most during COVID cannot be the ones who are going to pay the price of the economic recovery, which is so often the case in other kinds of situations. I'm going to stop my comment there, but I'm going to read a poem because I want to inject the voice of a person with dementia as we have this conversation. I've had the privilege through our dementia dialogue to talk to lots of folks on these issues, and Laura was on and we appreciate that. Christine Thelker, who's on our web chat today, was also interviewed. Our next podcast, I'm going to be interviewing a woman who wrote a little book. It's reversed here. Her name is Myrna Norman, and the book is called Dementia Strategies, Tips, and Personal Stories.
David, sorry to interject.
Yes.
Sorry to interject. I was actually going to close out with, really wanted to wind up our whole conversation with you and bringing forward that voice. So if you don't mind just hanging back a little bit, I don't want to scoop you because I was very purposefully wanting you to give you the last word today to bring that forward. So you're ahead of me. So thank you for that. And a good plug, we will definitely mention Dementia Dialogues And you mentioned just quickly age-friendly, and I've been involved with that movement, and it's a great movement. But again, we always say the same thing that you said. If it's age-friendly, we want to look at making it friendly, or making it inclusive and accessible, not just friendly, for everyone. And again, I think that's really important. So Nathan, I'm going to come back to you, and I know Laura mentioned in the chat a very good point, and I think that speaks to what we talked about at the beginning. Again, the what, like that's in a sense, again, a form of ageism in the system. So if you could speak to that, but also from the kind of the now what going forward, really think about what do you think is reasonable for us to, or what can we be doing in the next few years, or 5 or 10 years, in terms of solutions to work towards that anti-ageist healthcare system?
Sure. I think just to pick up on one of the pieces that David talked about, which was the intergenerational sort of solidarity, my perception is that we've more had intergenerational warfare during the pandemic, and that we've really have, created a larger divide. The perception among young people, those who are most in some ways economically impacted and socially impacted I think everyone's been socially impacted in many ways, but I think for a lot of people, they feel like they're in the waiting room of life. And the reason they're in the waiting room of life is because of old people, and because of the fact that we need to protect old people. And there is some blame, I think, and there is some resentment that we have shut down our society and our economy to save people who had disposable lives, to put it bluntly. But I've really seen this intergenerational warfare. It sort of struck me, and this will get to your larger point. I was listening, I know we seem to all be CBC fans here, but I was listening to, I believe it was Matt Galloway was hosting a chief from the Yukon, and he asked him why he had chosen to put forward public health measures for voluntary self-isolation that were more stringent and stricter than what the medical officer of health was recommending for Yukon. And he said, if we as a community lose one elder, the tragedy that would be, not only in terms of the loss of that human, but the loss of knowledge and the breadth of knowledge and the encyclopedia of horticulture and botany and stories and history and language would be so devastating that not only as a leader did he feel this was necessary, but the community bought into it. And I think what we've seen during this pandemic is that our leaders haven't necessarily always bought into, let's do everything we can to protect the lives of older adults. And certainly society has not always bought into it as well. And I think that has been a fundamental issue in this pandemic. So when we talk about building an anti-ageist healthcare system, why is it, and sort of to Laura's point up front, we have had a really remarkable social awakening in 2020 in a really good way. Right, we're talking about issues of race and other forms of societal inequities in a really important way. But age always seems to be overlooked in that conversation and is not explicitly addressed. And why is that, right? And so if we are going to promote fundamental change within a healthcare system, we need to rebuild the intergenerational solidarity that I think we've lost during this pandemic. We need to, and that will ultimately, from the ground up, promote not only a healthcare system, but a society that actually better values older adults. Because we have to question before this, why did we build a healthcare system that made long-term care the only option for many older adults, and that made long-term care an unsafe option? And so unless we go back to building a healthcare system that provides a diversity of options for people to age in many different places and access services across the spectrum of and continuum of our healthcare system, we will not be building an anti-ageist healthcare system. We will only be forcing people into basically what we have now, which is two options. Well, it's not two options, it's one option. You exceed, publicly funded home care and the very limited supports we can provide you, and you have to enter long-term care. And we force you to make, a couple choices. And if you don't do it, you start paying. I mean, in many ways, we force people and we do not let them age the way that most people want to. And so I think rebuilding that intergenerational solidarity, undoing the harm that has unfortunately also been created during COVID-19 to really
drive a wedge between generations is something that's crucially important in the wake of COVID-19 to building a better system moving forward.
I muted myself, so I don't mute myself because I forget to unmute. And I just, the concept of that intergenerational solidarity, I think, is very powerful. And I'm looking at some of the feeds that are coming up. Again, looking at teens and adolescents that have had that positive influence from their elders and their older adults in their life. And I think, you know, in many cases, we've really lost that over the years, and getting back to that. And I just, I was really struck something that Laura put in the chat box about people talking about segregation. And I just randomly was talking to a person in my neighborhood a few days ago, and she just doesn't know me, doesn't know where I work, and didn't know that I was hosting this webinar today. And kind of oddly got into this conversation about, you know, well, the average age of people who have COVID is above the typical, you know, age expectancy. So it's almost like they should be happy that they got these extra. It was really, really a really weird conversation. And again, she said, oh, we should just lock down long-term care, have the staff all live there, and just open everything else up. So it's just, and again, this, I'm not judging. This seemed to be a woman who I'm guessing was probably herself in her 60s. So again, it was, yeah, it's kind of out there, and sometimes it comes across and you're surprised but not surprised.
I want, if I might make a comment, I don't want to be too inflammatory here, but we have been, the public policy discussion in this area, we have been sold a bill of goods, talking about the initiatives that are being taken to protect people in long-term care, when in fact, hardly anything has been done to protect people in long-term care. Issues related to, you know, the stability of the workforce, adequate compensation, adequate sick leave. These are issues that were early recognized, and very little has been done. Issues related to, you know, building more long-term, you know, building more beds, or looking at home care. I mean, this is like such an obvious solution, is to strengthen the home care's capacity to enable people to remain at home. These are not fundamental restructuring of the way we think about long-term care, but they're policy decisions that have been sitting around in Queen's Park for 30 years that have not been acted upon. So it seems to be, you know, there is language coming out that would suggest that action has been taken. And that misleads younger generations to think that they're paying a price for something, when in fact, hardly anything has been done. And there's this kind of smoke screen of activity, when in fact, behind the screen, there has been hardly any meaningful action. So I think we need to really challenge the political debate and to help people understand that it's mostly smoke and mirrors that we're observing, and it leads to that intergenerational strife. But my goodness, it's not based on any kind of real action being taken. It's just being based on language being spoken.
Thanks, David. And yeah, very powerful words. And I'm going to move to Laura to comment on that. And I also have a final thought for Laura. Laura, did you want to comment on something that Nathan said first before I spring this on you?
Just very true. And I actually love this article that Nathan wrote, and been trying to spread it far and wide. And I think it's more true now than it was when you wrote it, Nathan, and that's not a good thing. One of the pieces that I really welcome is actually paying attention through the lens of liability, because if you're thinking about system changes, the notions of social good and moral good and so on are important, and they're, you know, key to our discourse. There is a harsh and perhaps less palatable, that's an ironic term, palatable. I'm looking for, not palatable. I'm looking at you guys, Nathan. I'm thinking of palatable. A more palatable approach which is to actually be looking at where liability sits. And so we're not always thinking about liability in the area of older people or liability in the area of justice and so on. And yet we know with the feminist movement, with the disability movement, with the Indigenous movement, and many, many more other movements, unless you actually get the narrative of rights and justice and liability and criminality and so on as the pointy end of the stick, you have a lot of lovely soft words and nice ideas. And so I really call to my own group that it is time for us to be part of the solution. And there is irony in a little bit also in the sense that much of this will be driven by insurance and reinsurance. And if you just look at the issue of infectious spread insurance for liability for long-term care, which is now mostly not available broadly in this country, we need to do system change because insurance companies won't back issues. And so let's not forget, as we're thinking socially, and let's not forget as long as we're thinking medically, that there's an enormous role for rights and law and justice. And so I'm hoping that my group really steps into that space.
Thanks, Laura. And I wanted to bring this back, and you've touched upon this a little bit, but I was doing a little digging, and I noticed that you were quoted in a Toronto Star publication, the January 1st, start of the year, where they talked about the different notable Canadians were asked what they were hoping for in 2021. And this is, again, January 1st, just about a month and a half ago. And you stated, my hope for 2021 is that this pandemic accomplishes the unprecedented, an end to ageism and the beginning of valuing seniors as equal citizens, deserving of dignity, respect, and care. So do you still have this hope a month and a half on? And any thoughts about quickly about how we might, about how we might get there?
I think I have this hope, and I see my colleagues here share the hope. And those of you who joined this conversation, you join the conversation because you have hope. We don't get out of bed in the morning with hope. And it's the energy of this group, of this collective, of you at home supporting yourselves and each other that actually is driving this forward. So I absolutely have the hope, but it doesn't mean I'm blind to the barriers. And I think, hope without reality is an optimism that makes you fall off a cliff. Hope with a confronting of your reality is what drives social change.
Thank you. And I'm going to save a little bit of time for questions, but David, I promised to circle back. And my question for you was really perfect, because what you're going to say, and I really love the work that you do with the dementia dialogues. And I know you've spoken to some really, again, some passionate and inspiring individuals who are living with cognitive impairments and dementia. So perhaps you can speak to some of the lessons from them on overcoming ageism and stigma associated with dementia. And perhaps that poem will speak to this.
Yeah, well, I've been quoting some people throughout. So the culture of silence is one of the phrases that was used in a conversation we had a short while ago that I thought was really powerful. The other phrase that I came across was courage is contagious. And we're talking about the culture of silence. The first time you speak out is a courageous act. And I think a lot of one's audience would appreciate that. And it gives encouragement to other people than to speak out or to respond. And I think that's part of what Laura was talking about and Nathan about the intergenerational fairness, is that we need to give an opportunity for people to exchange with each other so that younger people can witness the courage of an older person, admitting perhaps a disability, admitting that they have dementia, but at the same time, resolving to live their life as fully as they can. And similarly, I personally think the hardships of teenagers and young adults during this period of social isolation is probably wears more on them than it does on some of us older people. So I think we really need to foster that intergenerational contact in as I don't know, as in natural a way as possible. I don't think kind of forming, I don't know how we'll do it, forming groups of intergenerational conversation isn't going to do it. I think we need to foster more natural ways of doing it, and maybe to, through both organizations like Alzheimer's societies and other organizations to foster that kind of conversation. I will read this poem now, though, because I think it's important that I heard of Myrna Norman. She is a person who lives in British Columbia, is an associate of Christine's on the Dementia Advocacy Canada. And I saw a video of her giving a speech to a group in Vancouver, and she read this poem. Actually, just to slip in a little bit of advertisement, my conversation with Myrna is going to be released next week on Dementia Dialogue, and Myrna is going to be reading another poem on that particular episode. But this poem is entitled "My Search." I searched the books, the pamphlets, and I searched the computer too. I was looking for encouragement. I was looking for joy, but to no avail. Cancer, heart disease, and arthritis had words to offer comfort and hope, but dementia stood absent from the notes, in a way kind of fitting, already erased. Yes, without hope of some positive news, without even being included, it seems that society has no patience to learn, to share, and to include due to stigma. But wait, we can change the scene. We can make the change. Let's all work together to share our stories. Some sad truths, but some funny, happy times. Can we all pledge to understand, to search the facts, to help live well? Let's give of ourselves for the sake of others. Let's truly be our community's brothers. And I think that's really the call to action in terms of our own individual lives, to take responsibility for ourselves and then to take responsibility for each other.
Thank you,
So
David.
that's Myrna's phrase, yeah.
And we'll look forward to that next episode of Dementia Dialogues. Make sure everyone has the link for that. So we just have a few minutes left. If there's any comments or questions that any of the panelists have noticed in the chat box already that you wanted to speak to, or if you're listening, if there's a specific question that you wanted to ask one of the panelists, please that into the chat box right away, and we'll get to as many as we can. I see Chris. Oh, sorry, David, go ahead.
Yeah, I want to pick up on this, just what's on the screen right now, and ask Laura and Nathan maybe to comment, or others. And that is, when we're talking about dementia, we are talking about a stage in the lives of some people, at least, where they're going to need a concerted support system to provide care that isn't available in most people's homes. So we're talking about people having to relocate to some other kind of a setting. Small scale homes, it seems to me, are a very realistic option when we're talking about the care of people with dementia at that stage. If you do the math around the most, one model of home care in Ontario, shared care, and you do the math, you can put together a group of about 6 people and provide 24-hour care to them for the same amount of money that we're now investing in long-term care or in shared care. So it seems to me that we're not far away from an economic model that might be able to enable us to achieve more of a shared care, small scale model of providing. But we've got a huge industry and a huge sector that is driven by an institutional model of care. And I wonder, I'm just going to leave it there, but I think talking about alternative models of residential care are one of the things that needs to be amplified as we move out of the COVID-19 and start looking at alternative futures.
No,
Thanks,
we're
David.
in a number of different types of housing and care. Many of you will be familiar with things like vertical aging or naturally occurring retirement communities. Many of you will be able to be very familiar with campus of care model for those who may need increased supports or who are living with people who have flexible care needs. So they may come in and out of higher levels or more acute care. The good news is this, we've got great models. And we're building new ones all the time, whether it's co-housing model or changing municipal bylaws to allow carriage suites, whether it is allowing, and I use the term allowing because I was part of a law reform initiative to change legislation that banned older people living together without them being qualified and called a retirement home. They just wanted to buy a house together and live in the sort of Golden Girls style. Many of you will remember that. We actually had to change the legislation to allow it, because the assumption was is if a number of older people are living together, of course it must be some type of congregate, institutionalized care. The great news is we've got lots of different models. And I think, working in that care at home model, wherever the home is critical. And Nathan has been central to the conversation around bringing, care at home in. And I'm just going to toss it over to you, Nathan, but I can tell you from our point of view, both were very supportive of or part of those conversations. We're part of research grants on intergenerational housing right now and evaluation studies across the country. And it does require, I think, less concern than is often being given, because we actually don't have enough institutional care anyway. So people are saying, well, we're going to have to deinstitutionalize. I'm like, yeah, well, that's true. Don't get me wrong, we do. But we'll always need some form of long-term care. I think it needs to be better and smaller and a different style. But the reality is we really need care at home. Nathan?
Yeah, at risk of, or I want to get to other people's questions, but I think one of the things that COVID-19 has shown us is that less people want to live in long-term care for understandable reasons. And we also have to acknowledge that the post-COVID-19 world is not going to be the same as it was pre-COVID-19. And we're probably entering a new phase of our reality where we live in sort of the, I don't know what you want to call it, but the post-pandemic era, right? And congregate care settings are always going to be at risk. The COVID-19 is going to be endemic. It's never going to be eliminated. And so I think there's going to be not only a desire to enter or to have less people enter these facilities, but there's actually going to be a real infectious disease, infection prevention and control, urge and really motivation to do so. So yes, I think we need to be looking at a diversity of options for aging in place. I think the naturally occurring retirement communities or the NORCs are a really good place. I think David's model is a very, a good one as well. There's a model in the United States actually that I always come back to called it's a medical model at home where they actually have veterans who are taken in by people who want to be, so a lot of them are widows or people who are looking for a job later in life, and they look after 5 or 6 veterans. And there is a, that intergenerational solidarity is there because we value veterans in that way. But there are certainly other models that could very much look like that don't involve, yeah, I will, Laura, that don't involve, it's actually called elder foster care. And I'll put the link in the chat box. But yes, we need to invest in that. And also, look, there's comments in the chat that I'm looking at from people like Bob Murray, who just mentioned, the fact that people used to look after older adults. The problem is we don't value family caregivers. We don't provide them. 75% of all home and community care is unpaid from family caregivers. We don't provide them with the necessary financial supports. We make them dip into their own pockets. We don't remunerate their time with proper tax relief programs and tax credits. And we penalize people who look after their older adults in the community and choose to do so by not affording them the same financial supports that we provide to people living in long-term care. So yes, we are going to need to look at all of these options moving forward.
Thanks, Nathan. And I think it was the National Institute on Aging that produced that report, because that is an excellent report. So if you can reshare that, we'll make sure that it's included, because I was getting questions even from leadership within our own organizations about the foster care model, which I thought was excellent. And I'm like, what? How have I not heard of this before? So I think just bringing in all of those models internationally and see what's working. Again, we don't have to recreate the wheel, find out what's working well in other places and you know, tweak it for our own needs. So we're just at the end of time. I really do want to thank very much our amazing panelists, Laura, Nathan, and David, for taking time out of your very busy schedules to participate in this very important discussion. And we know that it will certainly inspire further conversation. And I do also want to thank our attendees for their very active participation and for attending this month's Brain Matters webinar. Again, we'll make sure the recording is available. And thanks again to Ian Wright of Scott Petrie Law Firm for supporting this month's webinar. So I'm just going to do a quick share because I want to share my slides here. Little promo for what's coming up next. Oh goodness, too many buttons to push here. Share my screen. There we go. That was not smooth at all. So I do want to, again, thank everyone. Our next webinar will be featuring author Irene Walker, who I've had the great pleasure of meeting virtually. She's from Southern Ontario, and she'll be talking about a book that she wrote called Forgiving the Man Who Forgot, Grateful Gratitude Attitude. And again, I know you'll be really inspired by Irene's message. And also just, we will have an evaluation that will pop up when you leave us. And if you could give us some feedback, that would be very much appreciated. And finally, this is how you depart. So thank you very much for joining us. And to depart, you can also scan that little QR code to access the evaluation, or it should pop up when you depart today. So thank you all very much for attending, and thanks again to our panelists.